Thank you, and thank you for taking the time to come and spend time with us today. I'd like to thank the Foundation for Sarcoid Research also for setting this up and inviting me. When we talk about ocular sarcoidosis, it's really it can present in many ways, and when we discuss sarcoidosis, we really describe it as really any manifestation in or around the eyes. And there's two clear distinctions, though. We have a group of patients who get this acute and severe onset of inflammation in their eyes, are very symptomatic, and come in immediately. The ones we worry about more are the ones that present with chronic disease and can be completely asymptomatic until very, very late stages of their disease when they've already had significant permanent vision loss. And the problem is both groups, both the acute and severe presentation and the chronic and asymptomatic, often are misdiagnosed, or the diagnosis is missed until the ocular findings are very severe and there has been permanent vision loss. When we talk about ocular sarcoidosis, we really see that it can affect any ages. Children can get it, and then very, very elderly patients can get it. But there's two peak incidence ranges, and it's in the 20s and 30s, and then we see a second peak in the 50s and 60s. And what we find is that 30 to 60% of patients with sarcoidosis will develop some type of ocular involvement, and the number varies based on which populations you study. So looking at the U.S. population of African American patients specifically, it's closer to the 60% group. Or looking at some of the Northern European and the Caucasian populations, it's probably closer to the 30% number. So that amount varies between patients, and the presentations can vary as well, where African American patients typically will present with more acute onset and will be very symptomatic, whereas Caucasian patients and elderly patients will typically be very asymptomatic and will not have any symptoms and will be diagnosed based on an eye exam that they get. We know that 5% of patients approximately who have uveitis, which is inflammation inside the eyes, will eventually be diagnosed with sarcoidosis, and for 30% of patients with sarcoid, the eye inflammation is the very first manifestation, and then eventually they go on to develop either other symptoms or, based on other testing, we diagnose that they actually have sarcoidosis. So how do we diagnose it? Well, the gold standard is still biopsy, and biopsy can be from any site. It can be from the eye, but we tend not to do it from the eye because there's a really high risk of vision loss with biopsies from the eye itself. Sometimes on the surface of the eye or the lacrimal gland, which is the tear-producing gland above the eye, that you can safely biopsy, but biopsies inside the eye tend to be very risky and they tend to be associated with significant vision loss, so we tend not to do that. So oftentimes we work in a multidisciplinary approach, meaning we work with the dermatologists or the neurologists or the cardiologists or definitely with pulmonology, and Dr. Ribeiro can tell you that we share a lot of patients and we tend to use a lot of ancillary testing to come up with a diagnosis. How does it manifest in the eyes? Well, in a lot of ways. And so we can see things such as scleritis, which is inflammation of the white part of the eye. You can see the lacrimal gland involved. A lot of patients will complain of dry eye or blockages of the tear ducts. You can get granulomas on the conjunctiva, which is the skin of the eye. You can see it as just a droopy eyelid initially can be the first manifestation. And then you can see inflammation of the eye muscles or glaucoma, which is an elevation of the eye pressure. And then inside the eye, in terms of uveitis, there's a wide variety of presentations, and it can be any of these or all of these all at the same time. And we have patients who have very, very subtle signs that are often missed for long periods of time, and then we have other patients who have no symptoms really, but then when we examine them, we see multiple signs. So for diagnosis, we really do recommend and have been advocating that the Sarcoid Center for yearly eye exams with all patients who are diagnosed with sarcoidosis. And it's important that you see an ophthalmologist and not an optometrist, and if it's possible, to specifically see a uveitis specialist. And if you can't find a uveitis specialist, because there's only about 200 in the country, a retina specialist would be the second best choice. And anyone who's symptomatic, which I'll run through some of the symptoms that you may develop, we recommend an immediate eye exam. And so what are the symptoms? Well, it really depends on what manifestations the patient's having. So if you have scleritis, which is inflammation of the sclera or the white part of the eye, this will be a red eye that remains red constantly for multiple days and will be very, very painful. And patients often describe this as pain kind of shooting through the back of their head, and that's just constant, boring pain always there. But then you can have just lacrimal gland inflammation where you'll have a little bit of dry eye and there can be some tenderness when you feel right above the eye, but nothing else. They can have granulomas of the conjunctiva, which usually aren't symptomatic, but they can be tender, or you sometimes can see these enlarged nodules on the surface of the eye itself. With orbital myositis, you would have pain with eye movements. And with optic nerve granulomas, which is an actual sarcoid granuloma in the nerve that supplies vision from the eye, you'd either see dimmed vision or loss of a portion of the visual field. With uveitis, well, it depends on the type. So if it's the acute onset where it comes on suddenly, there's lots of pain, there's redness and light sensitivity. That's the classic triad that we talk about in patients with uveitis, is the pain, redness, and light sensitivity. But in the chronic form of it, you don't have any symptoms, and patients will often be what we call have silent uveitis, where they don't have any symptoms. They may notice some floaters, they may have decreased vision, but their history is often not very precise, and this goes on for long periods of time before they present. Whereas the acute onset, there's a definitive start date. You know when the eye started hurting, when it became red, when the light sensitivity started, and oftentimes it can develop, last for a few weeks, and then get better on its own with the acute onset, whereas the chronic is just slowly brewing and slowly getting worse. So I'm going to just show you a few pictures of a few different manifestations of this. So this is a normal eye, just looking at the front of the eye. We're looking at a few different things. So you can see the colored part of the eye. Not working there, we'll use the mouse. The colored part of the eye is the iris. This is the light beam is on the cornea, which is the clear front of the eye. This is the pupil, and then the white of the eye out here is the conjunctiva and the sclera. When we talk about inflammation in the front of the eye, there's a lot of different ways it can manifest, and so just to kind of show you a few different things. So myositis, which is inflammation and swelling of the muscle, and you can see this muscle here compared to this muscle is much bigger and is very inflamed. You can have just lacrimal gland being inflamed, and you can see there's this lump or nodule right above the eye. You can get granulomas on the conjunctiva, so this is underneath the eyelid, and these are actual little lumps and bumps underneath the eyelid from sarcoid granulomas. You can have scleritis, where a big portion of the eye becomes red and very inflamed. And then you can have actual granulomas inside the eye. So you can see these as iris nodules throughout the iris. This is very severe. Typically, it's much milder. You can have inflammation where these are actually inflammatory cells sitting on the back surface of the cornea. It's another picture of that. And then patients can develop cataracts and can develop what we call synechiae, or adhesions between different parts of the eye. Inside the eye, we can have something we call snowballs, because that's what they look like when we look inside the eye, is these white deposits of white blood cells that are accumulating inside the eye itself. And then you can have inflammation of the blood vessels inside the retina. You can have inflammation of the optic nerve or multiple blood vessels. And then, so to really, not to show you what these are, but to give you an idea that there's a wide variety of ways and differing severities that you can see with sarcoidosis. And this is why I was saying that it's important to, if possible, see a uveitis specialist and not just an optometrist and not just a general ophthalmologist for a yearly exam if you have sarcoidosis. And I do think that that's important because things are often missed. And so in the interest of time, I'll pass some of these slides by in terms of the manifestations. But when we talk about treatment, it really is a multidisciplinary approach where we have to see how much systemic involvement there is. And I think that oral steroids or oral prednisone is a good starting point. But I think a mistake that's often made by many folks, especially in the eye care field, who are not familiar with treating uveitis, is that they leave patients on steroids for long periods of time. And that's a major mistake because steroids have side effects, as you've heard already today. But not just the side effects, oftentimes you aren't adequately controlling the ocular disease with just steroids because you need very high doses of oral steroids or IV steroids to get an effect in the eye. And so we use a multidisciplinary approach where we work with the pulmonologist and work with the other care providers to make sure that the systemic disease is under control, and then use either steroid-sparing agents that are taken orally, such as methotrexate or mycophenolate or leflunomide, but then also some of the newer treatments, such as Humira or Remicade, and then supplement it with local treatment. So we can actually give steroids as eye drops for the inflammation in the front of the eye, but can also give steroids as injections either into or around the eye to treat inflammation inside the eye. And I think that the first point that I was making, though, is the most critical one, is that leaving someone on prednisone orally for a long period of time is not the correct way to treat this. And you often will end up with many not just side effects, but you can have some very, very severe issues in the long run. And the key take-home point that I want to give you is that with adequate treatment, you can control the inflammation in the eyes over the long term and in the rest of the body. And with good control, we can prevent vision loss. And oftentimes patients will come to us at a very severe stage where they've already had permanent vision loss, and we can't reverse it, but we can prevent any further loss by controlling the inflammation. But it's important that the inflammation is caught as early as possible. So again, regular eye exams are critical. I recommend at least once a year if you have a diagnosis of sarcoidosis. And again, if you can, with an ophthalmologist is preferable, and if you definitely can, then with a uveitis specialist. If there's not a uveitis specialist that you can find in the area, oftentimes a retina specialist will be the second best choice because they are often more comfortable with treating uveitis or inflammation in the eyes. And the second take-home point is that with proper control of the inflammation, patients don't lose vision. And we can maintain vision long-term and actually can keep you seeing very, very well long-term despite having very severe ocular disease. And so we're very fortunate that at the Cleveland Clinic we have 5 uveitis specialists, which again, there's about 200 in the country, so having 5 here is a very big luxury. And then we also have a uveitis fellow, so spends a year with us training in uveitis, and then a team of 2 nurses who help manage all of our sarcoidosis patients. So if at any time you need to be seen, there's always one of us in clinic, and there's always somebody available and willing to see you. Thank you.